Senate Bill 1142 and its companion bill, House Bill 2976, and it relates to the authority to hire physicians. In the event that we do have a quorum, we'll ask, I guess, Vice Chair to call us into order. Right. And council will walk you through that protocol to be able to call the meeting to order as well as adjourn the meeting. So we'll pause should we have a quorum walk in. So I've stated what the purpose of this is. I would ask that, we do have some prepared slides that are in your packet. Allow us to work through those slides, and then we're going to move through these as quickly as we can to allow as much time as possible for questions from the members. This is a public workshop, and so unlike regular board meetings, we may turn to others that are also in attendance from time to time and ask questions or get their insights as needed and necessary. So with that, we'll turn it over to Perla.
May I ask one question with respect to that?
Absolutely.
Yeah. Okay, so is this an opportunity for the public to have input, or are we going to have a separate meeting where the public will be able to come and have input? Because I think that if that's the case, then we need to make sure that it gets better notice.
I think at this workshop, depending on the questions from the members and the time, if there's some conversations that we need to have with the public, absolutely. But I want to make sure that we answer all the members' questions as much as possible.
I understand that, but my question was whether or not there was going to be a public hearing with respect to this legislation that is going to impact Central Health and change the statute. I'm asking whether or not there is going to be a public hearing conducted and by that I also mean including notice and putting it on separate and apart from this. This was for basically us, is my understanding.
So that's a priority call of the chair. And I would suggest that you visit with Dr. Zamora about that if you'd like a separate public hearing.
It's a priority call of the chair. The chair decides when we have public hearings. It's my understanding that we're a public entity, and that if there is going to be something that we as a public entity are going to be discussing that is going to significantly change our statute and how we may or may not do business right now or in the future, that it does need to be done in a public meeting where the public is allowed to participate.
Understood.
And that's just, I have to say that for the record because I don't believe that, because I believe that by not doing that, that we are not acting in an open and transparent manner. Thank you.
And for the record, I'd like to say that all bills that are heard at the Capitol are heard with public hearings.
That's right.
So individuals that would like to speak toward those bills can go to those hearings, sign up as a witness, and speak. So that's,
I understand that.
I'm not contradicting you.
No, I
I'm
understand.
just saying that the public can be involved.
As a follow-up to that, sir, I don't necessarily I do believe in the public process when we're in a legislative biennium session, as we have now. But I do believe, more than anything, that if there is something being presented to the public in a legislative session or in any other session that impacts Central Health and changes our statute and changes how we do business or provides additional options to us that would cause for a change in how we do business, I think that that needs to be done in our public purview and within the confines of Travis County to show that we do honor the public's input and that we do honor the process. Thank you.
Sorry.
Thank you.
We actually what?
We're going to call our meeting to
Yes,
order now because
that's right.
we have a quorum of our board. Sure, I think we should sit there.
Sorry, Mr. Ewan.
Council, if you could walk us through.
Does he need to call the meeting to order?
Yes, he does.
So, I have this for you. If you would just go ahead and do your normal introduction to the meeting, date and time.
All right, it is. Welcome, everyone. Today is March 20th, 2019. It is 12:05. I'm calling the meeting of the Board of Managers workshop today. Thank you, everyone.
And make sure you read agenda
Yeah,
items.
all right. Agenda item 1 is receive and discuss a presentation of legislative file during the 86th Texas legislative session that impacts Central Health's ability to appoint, contract for, or employ physicians. And John Morgan and Medical Officer will be presenting.
Can I now repeat what I said for the record as that we're now an official
So
meeting? Dr. Samoda? If I can,
Just let me, everything that Cynthia mentioned before has been recorded. We were live streaming before that, but if you would like to again,
Just
because
to
it will be
briefly reiterate for the purposes of enlightening Dr.
prerogative of the
Samoda.
chair.
Thank you, sir. I do believe Dr. Samoda, our chair, whom I support 1,000%, I do believe that whether we're in a session or not, a legislative session or not, and whether or not there has been pieces of legislation introduced that would impact how Central Health does business or provides us additional options as to what we can do in the future, or changes our statute in any way, shape, or form, that we, as Central Health Board of Managers, duly appointed by two entities, the county commissioners and the city council, I do believe that for the purposes of public involvement and knowledge and showing our commitment to open and transparent government, I believe that we should have a public hearing when there are such things presented either in the legislature that can impact us or whether the legislature is not in session, when there are things that are being presented that can impact us and how we do business. So I'm just, for the record, sir, stating that I believe that there should be a public hearing where the public is invited to participate and that they also receive notice about the two pieces of legislation that are being submitted. And this does not take away from their ability to participate at the Capitol, because this has nothing to do with whether they can or cannot participate at the Capitol. It has to do in what we, well, as far as me, as far as I believe, how we should do business, and that is in an open and transparent forum with the ability to invite the public to participate when there have been significant changes made to, or options presented to us, and how we may or may conduct ourselves in the future. Thank you.
Thank you, Chair. I just would like for the record to say that we are having this meeting. It is an open meeting. Individuals can watch this via YouTube. They will know the legislation that we are proposing in the Capitol. As with all other citizens, they can go to the Capitol and register as a witness and be for, against, or on the bill. And I'm not sure what additional information we would receive from the public at a hearing here that we would not receive at a hearing at the Capitol. So, for the record, that's where I stand.
Thank you, Dr. Bell. Ms. Giesler, may we proceed with the presentation?
Well, I'm going to actually put a pause on this. Members and Dr. Zamora, if it's the desire of the board to have a separate public hearing, we should probably pause these proceedings today, not take up your valuable time or staff time.
I agree.
Reconvene this. We'll have to repost it.
I agree.
And so that way everybody,
Yeah.
because this was posted on our website, and so it's posted and duly filed with the county clerk's office. But if it's the will of the board that, even this is a workshop, so anybody, after the board questions, like I was saying, anybody that's here could talk. You're not limited in the way that you are at a board meeting with
Right.
citizens communication. But if this doesn't suffice, then I would need to know that right now, because I need to dismiss staff and we'll conclude the workshop
Right.
and then repost it as a public hearing. So I need some direction.
Andrew Aldez.
I understand that as soon as we were informed about these proposed bills, that I asked for us to have an open session so that we could discuss them. However, it has just been brought to our knowledge, or to our attention, that tomorrow is the hearing at the Capitol on these pieces of legislation. And with respect to whomever is responsible for scheduling this, okay, I do believe that sufficient time was not allotted for the public to be involved or for the board members to have all of their questions answered. And I have raised this concern as a process concern so that we take into account that whenever significant changes are being proposed, are being developed by Central Health staff, unbeknownst to all the board members, that at the earliest possible time, that the board be informed that there is a movement to change possibly how things occur, and to let us know so that we can get like a heads up and we could better prepare ourselves for supporting a unified position and or at least presenting some concerns that can be responded to appropriately by the appropriate staff. And so I just think that that's something for us to consider for the future purposes. But I will say that
Can I ask Vice Chair if she had a point?
what's your advice?
I wanted to let Manager Valdez know that I completely understand your position, and that having not just noticed perhaps in a meeting a few months ago, but actually having a workshop much sooner in the process would have been, better as far as all of us being apprised of the details and what this could mean, and the public also. At this point in time, the hearings that were set in the legislature, we had no control over, and they happen at the drop of a hat. I mean, they have posting requirements, but it can happen very quickly, and I understand that's what has happened. That all of a sudden we just got notice, as did the public, that tomorrow there's going to be a hearing. So my concern is that if we don't have this workshop now, that we will not have had the discussion that you and all of us desire before the hearing tomorrow. So that is, I think, the fork in the road at which we find ourselves right now. But I completely understand and concur with your desire for having these types of workshops earlier in the process.
Yes, and Manager Valdez, I'm going to go back to a conversation that relates to this legislation that you and I had prior to this meeting. It was after the last board meeting. And I take full responsibility for the lack of process here. That's my fault. But I think what's interesting about this piece of legislation and the other legislations that's been mentioned is this is the first year that we've had proactive legislation. Up to this point, I've not had a conversation with the board about what kind of process do you want. We simply brought this to strategic planning, these concepts.
Right.
Granted, it wasn't the bills, it was the concepts back in December so that you all were advised. And then we just proceeded to go do. And so staff has done exactly as I've asked them to do. But having said this, and like I was telling you last week, in the CEO's item that I anticipate will be posted for the board meeting next week, we can certainly bring up, and I already have some prepared remarks to bring up these process issues. And, again, I take full responsibility for this. And I think at that point in time, we can have some continued discussions. And if there's a reprimand associated with that, I fully accept it. But what I need to know now is, do you want us to go forward or do we stop?
So if we could just wait for Dr. Zamora to come back because we've lost our quorum.
Right.
We can discuss, but
There he
it's just not clear.
There he is, the man of the hour.
Don't.
Water this morning. Mr. Giesman,
Do
would you like for me to take a vote?
do we
No,
proceed
I
or
don't.
do we
Let's see what Manager Valdez has to say, given our discussion.
do we proceed or stop?
I just would like to tell you, Mr. Giesman, that I appreciate your comments. I'm making my notes and my comments for the record because this is the only place I can.
I understand.
And so with respect to the way we conduct business in the future, and if we need a process change, let's make that as soon as we can. I do believe that if this is our only opportunity before the hearing tomorrow, that I would like to hear everything that is going to be said about this. There may be questions out there that those of us at the table may not be thinking about, that the public might have with respect to the proposed language. And so so long as they have an opportunity to provide it. Maybe it won't be in time for the testimony tomorrow, but if they can provide it at a future, as soon as possible, date, I'd like for us to move forward with that. However, with respect to this, the time is upon us, and I do believe that we need to hear.
And that's how I feel too, Cynthia.
Yeah. I do.
We're as Vice Chair said, these committee hearings that they're going to have tomorrow are not up to us. It's whenever the House will convene this bill. In my personal opinion, as the chair, Mr. Giesland, as I would prefer to let's hear the presentation.
Okay.
I would prefer to go on.
Thank you.
And because we have a little time constraint with Manager Dr. Bell because he's got to leave on a flight.
All right.
So, Pedla, John,
Yes,
thank you.
thank you. We'll go ahead and begin. And I also hear you, Manager Valdez, and we will work on some processes moving forward. I wish we had more time, but the legislature only meets every other year for 140 days. We're halfway through that session now, and if we want this legislation to pass, it needs to be out of one of the chambers in the next 2 to 3 weeks. So we don't have much time, unfortunately. So I'm going to walk through, we put together a PowerPoint presentation right here, I guess. I'm going to start by just introducing the bill and just saying a couple of things about it. The legislation, Senate Bill 1142 by Senator Watson and House Bill 2976 by Representative Donna Howard, would give Central Health, the Travis County Healthcare District, the authority to appoint, contract for, and employ physicians. I think the bill is in your board packet. It is straightforward. It creates a new section in statute that allows us to appoint, contract for, or employ physicians. It also speaks to some protections to the practice of medicine that would require the creation of a medical executive board, policies that should be adopted, and oversight. In addition, I want to say that the statute would be effective immediately if it receives a 2/3 vote of both chambers. Otherwise, it would be effective September 1st of 2019. And I do want to say that this is standard language, the bill, that has been vetted by the legislature and by the Texas Medical Association. At least 17 other hospital districts have this similar language, and there are 3 other hospital districts seeking this authority this legislative session, including us. So I'm going to move on to the next slide here. Why do we need this authority? And I'm going to let John speak to that.
Good afternoon. Knowing we're a little short on time, I'll try to dive in. What I want to try to do is provide a little bit of context through some examples of what we are looking for out of this effort and the reason why we're pursuing it. I certainly won't speak to procedure or timing, but just from an operational perspective on the ground, this should not be a controversial issue. I think this is part of us evolving the role of the district and what we're doing in terms of making sure that as we go about our work, we're doing so in the most effective and efficient way possible, and that we're providing some flexibility to our staff and our practitioners on the ground who are working with our patients every day. So the examples that I want to give are really in 3 different areas. The first is in direct care. Today we're not able to use the people that we employ to the top of their license or to the best of their abilities because of our inability to practice medicine. To give you a few examples, we employ an associate chief medical officer, Dr. Jim Brown, is on our staff, works at the direction of Dr. Mark Hernandez. Today, Jim can't practice as a doctor. He can see a need, he can see a patient in front of him that has a need that he is qualified, able, and willing to help with, and he is unable to do so. I really can't tell you the number of times that it's late Friday and Dr. Hernandez and Dr. Brown are on the phone trying to coordinate a physician to take care of a patient before we hit the weekend. We are in a really good position at Central Health to help fill some of those gaps in transitions and gaps in care for our patients, but today we can't do that. We're fortunate to have partners like Seton and partners like Community Care that when we call, they help us, but this is where we can take a more active role. This could be something as simple as a patient is going to run out of their chronic medications on a Friday. They can't get in to see their primary care provider until middle of next week. And really the only option they have is to go to the emergency room to get their script refilled. And we all know that's not the goal. We also have patients that are homebound. Today we don't have great home-based services. We have several initiatives that are in that area. But if you ask Dr. Hernandez, he is more than willing to swing by a patient's home on his way into work in the morning and take care of something if there's a patient that can't get into the clinic. Nursing staff, as a second example, we employ 5 nurses today that are on our staff that serve in case management and in navigation type roles. If our patients are if our staff, our nurses are at a patient's home, helping them to plan their care and access care, and they notice something as simple as a bandage that needs to be replaced, a patient's wound that needs to be redressed, they can't do that today. They either have to arrange for transportation, they have to arrange for home care, or at worst, they send that patient to the emergency room. This would allow our nurses to do what they can do through the practice of medicine and establishing standard delegation orders for those nurses. And then I think that the third area of direct care, I think, is not an immediate area, but is one that we would want to consider going forward. Today we contract for services and we provide services through community care. This would allow us to consider other solutions where we want to have a direct role in providing health care, where there may not be a partner that's willing and able to see our patients. Home care is a good example of that. We talk a lot about e-consults, and an employment model around e-consults makes a lot of sense to us. It's something we want to at least evaluate, if not pursue, as well as certain specialties. Community care has limitations in terms of what they can get into their scope of project as an FQHC, and we want to be able to evaluate direct services as we move forward. The second area of examples I'll give are what I phrase as operational determinations of medical necessity. So think about health plan type functions that exist with other healthcare districts and with commercial health plans like the ones that we have. I'll do the best I can at a clinical example, not being a clinician myself. You have a patient with a hernia. Oftentimes the provider on the ground will want to order an MRI for that patient to understand the hernia. The health plan, in trying to be as cost effective and efficient with their resources as possible, is likely going to require a CT before they order and approve an MRI. We don't have the ability today to make those types of medical necessity decisions that we need to be able to make to manage our resources effectively. Another example, just in terms of what I'll call clinical triage, and just essentially making sure that with the limited resources that we have to work with the limited access that we often have to work with, we need to make sure that the most critical patients are first in line. Those are the patients that get scheduled and get access to the clinic first, again, based on medical necessity. The third part I've referred to already, just in terms of referral management. This is about making sure that the right patient is in the right line. Today, we cannot get involved in that process. We can't redirect patients based on the completeness of a referral or the appropriateness of a referral, and this would give us that ability. We could help make sure that people are going to the right place for services. And finally, the third area of examples I'll give to me are about the healthcare district itself having the appropriate level of clinical oversight for our patients, the care that they receive, the care that we pay for, and making sure that we have that level of oversight. A couple of specific examples around that are the development of a quality program. We have quality programs today that we work through with our providers from a contractual perspective. we need to continue to enhance our ability to have quality level oversight of the services that are being provided directly or through contracts. The physician credentialing process is another good example. We want to make sure that qualified and high-quality physicians are taking care of our patients. And then unfortunate circumstances of individual case review. If we have a patient that has a bad outcome, we need to be able to have our clinicians have clinical conversations about those outcomes and recommend areas for improvement. So that's all I'll speak to on that slide. I can talk for an hour just about the operational impact of this bill, but understand we have some time constraints today.
Members, on the financial impact of central health, and this, currently now, as John mentioned, we do have individuals on staff, so we don't anticipate any additional staff salaries. It's just an expansion of what they can do under their current licenses within their employment here. I think future operational plans, if we were to go beyond what we are doing now, obviously that's going to have a more refined fiscal impact attached to it so that you can have full line of sight knowing this is what it is going to cost, but also what the value is. I wouldn't want to look at it as just an expense. There's a value to our patients in this in the future. And then the last point, ultimately the Board of Managers decides the budget. And I think that, as you think through, the budget process and what that's like, there'll be multiple opportunities to have discussions around any expansions above and beyond what we would contemplate doing today if it's currently law.
I want to now speak a little bit as to why we need the legislation. Why can't we already do this? There are strict state laws and regulations around the practice of medicine and who can practice medicine. There's the corporate practice of medicine as well, which is illegal, and unless the legislature passes a bill to allow an entity to practice medicine. And the reason that this is important, I think even Dr. Zamora, I'm sure you could speak to this as a physician.
Dr. Bell can too.
We do not want a non-physician telling a physician how to diagnose, treat, prescribe, and refer a patient. So this is what the law protects. It protects physicians to make independent medical judgments, and it protects patients. So hospital districts that have gained this authority to practice medicine and to hire physicians to practice medicine have worked very closely with the Texas Medical Association to develop template language that provides authority to practice medicine by hiring physicians. Yet this language ensures that there's adequate protections. I don't know, Dr. Zamora, if you want to add anything to that, but it's pretty straightforward.
Sure. And you know me, Cynthia, I don't say a whole lot at these meetings. I keep my mouth shut and I listen because I learn from all of you guys at every one of these meetings. But this one I have to step up and say, what Bedla just told you is perfectly to the point. Our medical board, and Dr. Bell can tell you the same thing, is very, very strict on who can practice medicine and who can't. You have to have a relationship with a patient to be able to give orders and see the patient, correct, Dr. Bell? And so this gives the Central Health the ability to hire a physician, and we already have one. We already have several that can help us with that. So as I've told you in previous discussions with you, so the public can hear, this is a good thing. It's going to put us on the same playing field as the other hospital districts. I've spoken, as Pedla has told you, I've spoken to TMA staff. They're in full support of this bill, and their lobbyists are also in support. And I've spoken to the local medical society, our CEO and our COO, who are also in support of this bill because they know that it's not going to limit a physician's way to practice. And so that's why I believe in it. I truly believe in the bill. I think Senator Watson and Representative Howard have done a great thing. And so I will be there tomorrow to be your advocate at the committee meeting, and you're welcome to come as well. Vice Chair.
No, I concur, and also from what I have heard, this will make us a more effective and efficient provider of health care to those who who we serve, because we have people on our staff right now who we're already paying, and they cannot do what they are qualified to do. So I think that it will do that for us too, from what I've heard.
Correct. You're absolutely right.
Okay, I'm going to move on so we can get through this presentation and just a little bit of legislative history. As I mentioned, there are 17 hospital districts with the authority to hire physicians in practice medicine. I have that list if anybody would like to look at it. And also just a few key bills of the major urban hospital districts that have passed similar legislation in recent years. We, the Travis County Healthcare District, did pass, and were one of the first to pass a very narrow bill to allow the hiring of physicians for our FQHC only, and that was in 2007. And then in 2009, Dallas passed their legislation, and then in 2011, Harris, Bexar, El Paso, and Tarrant County passed their legislation. I'm going to move on here.
So if I could just, a point of information for the public who's listening. When you said for our FQHC,
Yes.
that's community care, which in fact is not a partner. Community care is part of our Central Health family,
Correct.
and it is our FQHC, correct?
Correct.
We're co-applicants.
Thank you.
Yes.
Okay.
Yes. And moving on, there are three, actually that's an old slide, so I'm going to keep it here. But there are three bills this session that have been filed to establish authority for Travis County Healthcare District, which is our legislation. Also, Lubbock County Hospital District and Hunt Memorial Hospital District also have legislation. Hunt Memorial Hospital District had a hearing last Thursday, and tomorrow Lubbock County also has a hearing along with us. And then just in terms of status, I think you're well aware we have a hearing tomorrow morning in House Urban Affairs at 9 a.m. For the House bill, and then the Senate bill, which is identical legislation. My understanding is a committee request form has been submitted, but a hearing has not been posted yet. And we will, work that bill through the process and keep you updated. That's our presentation for today. Now we'd like to open it up to any questions and discussion.
Julie?
I may have misheard you, John, but I think under your second example, you're talking about case management and nurses needing to be under the guidance of MDs
Yes,
for
ma'am.
case management, and that they were going to homes and not being able to change out bandage. Well, why would they be able to go to homes in the first place if we aren't allowed to practice medicine?
So when our nurses are going to people's homes, it's a navigation function.
Okay,
We're
got it.
helping
Yeah,
people to
that-
understand how to work through the system.
Got it. Okay, I see what you're saying. Sorry, I was thinking home health care.
Sure.
Okay, sorry.
We do a lot of telephonic work
Yeah.
as well, but
Yeah.
case
often with our patients, it's best to establish a relationship
Yeah.
face to face.
And I only bring this up because I do want this on the record, because I have heard rumors that we're doing this so that we can pay UT Dell Medical Center doctors and residents. Is that the case? Okay, just so it's on the record, that's not a no. So, that's one I heard from the public.
They're not our employees.
So, yeah, if I may ask a question.
Right, sure.
My understanding is that we will not be hiring or paying anybody additional, that what this will allow us to do is allow doctors who we currently have and are paying their salaries to practice their profession, which they're not able to do now. Is that correct?
That's correct.
Okay.
That's the intention for today. Anything additional to your
Would have
point
to come to the board.
would come back.
So anything beyond that in the future would have to come to this board, is that correct?
Yes, I won't speak for Mike, but
Oh, you're doing a great job.
Thank you.
And there aren't as
You
of
would
right
see
now,
it.
intentions to do that?
No, and you would
Once
see
this
it because we
passes?
would have an increase in our personnel salary.
Well, I'm just saying there's no intention right now to bring
No.
that before the board to
To do
pay.
what you just said, no.
Okay. And then since this legislation relates to the healthcare district, are the physicians going to be under Central Health or the CCC? I would assume Central Health because,
We're paying.
All
right?
of them.
Yeah, so the bill is structured so that Central Health is the employer of record, and there's a few reasons for that. I think one of the reasons is flexibility, but the second reason is almost all of the employees of the CCC are actually Central Health employees. Same for community care. All of the community care employees are truly Central Health employees.
Okay.
And that's why it's important for our terminology, it's not a partnership. Community care is part of our enterprise.
Well, but the CCC is a
No, I'm
partnership.
saying community care.
And that's what I'm like, I guess I'm thinking that if it's a partnership and we're bearing the costs of the personnel in the partnership, it's perhaps an inequitable partnership. And I realize it doesn't
It's
operate in
probably
the
for a
same
different item.
world as other partnerships, but I think that's why I'm wanting to know if they're under the Central Health umbrella or the CCC umbrella.
They're under the Central Health umbrella.
Okay. And then, why didn't we do it sooner? I mean, I'm looking at these dates, and I mean, they're all like 2009, 2011. Why wouldn't we have done it when, especially 2011, it looks like a bunch went through. Why wouldn't we have ridden the coattails of somebody else?
That's a good question.
Well,
Could we have an answer?
I'm happy to give my
Yeah.
perspective.
Yeah.
Please.
I haven't been here since the beginning of the healthcare district, obviously.
Right.
But as I think I mentioned earlier, I think this is just part of the natural progression of the healthcare district. At the time when the legislation was changed to allow community care to be able to hire physicians, that was the need at the time. Now we have a need and we have opportunities to take on additional roles that we've historically had to contract for. I mean, things like utilization management, credentialing, and even just physician services. I think we have an opportunity to, we're in a different place now. We're set up to actually take on some of those activities ourselves.
And I think when the original Travis County Hospital District legislation was passed in 2007 for the FQHCs, that was an immediate need that we had to transition those city and county clinics and their physicians over under the district. And so it was very narrow language just based on that immediate need.
Good question.
Bill?
I think I'm reading the bill to say that the medical board, or I take that back, the medical executive board of the
What
district
section is that?
is on page 2, and it is the third line.
Okay.
And will that have to be created here at Central Health? And also, that's my first question. My second question, I guess it is a question. On line 24, we talk about
The same thing.
a member of the medical executive board who is a physician shall provide biannually the chair of the medical executive board a signed statement. Okay, same thing.
Well, that would be me. There is a medical executive board, correct, Mike?
So actually, this legislation requires the creation of something that is separate from what you all know as the medical committee.
Right.
So it's a true separate board that would be comprised of physicians. It could be some of the physicians who are currently on our board, but it may be people like Dr. Hernandez and Dr. Brown and other physicians in the future that we may hire. So although there is nothing explicit in this legislation that would allow the hospital district to create the board, there are several cases out there, as well as Attorney General opinions that suggest hospital districts have implicit authority to do anything that is necessary. And so it is necessary under this legislation to create a medical executive board, and you would have an implicit authority to create that board.
Sorry, Charles, and I was wrong.
No.
Thank you, Helen.
Is that it,
Thanks,
Dr. Law?
Helen.
Yes, that's
Because
all.
I just have a question to follow up on that exact point. if I can ask it, Holly or Dr. Zamora. So with
Okay.
respect to that, on page 3, line 2, this medical executive committee will exercise independent medical judgment in all medical executive board matters, including those that are listed. So when we use the word independent, to me, that means independent and free of any possible conflict. So when you have somebody that's on the Central Health Board, or if you have somebody that's an employee of the CCC, or you have anybody that benefits from Central Health or our public taxpayer dollars in any way, shape, or form, then that puts them in a conflicted position. How are we going to be able to exercise or implement true independence if that word is included here? If somebody can explain that to me.
So I think right now there is no thought about who would be on this board, but it would be something that you, as members of the Central Health Board, would have direction in providing who should be on the board. If you believe it's not people who currently serve on the Central Health Board, then that is your prerogative, and it may be discussed and decided by the board.
But I'm also, it's not necessarily a reflection on Central Health board members. I'm talking about CCC staff. You mentioned Dr. Jim Brown, who is already currently an employee, even though he doesn't exercise his practice of medicine on our patients due to the prohibition of corporate practice of medicine. So how are we going to do this? I mean, I understand using the words,
Can
but
I
there
speak
needs
to
to be
that?
some context.
Yes, Manager Valadez. This language is, template language by TMA, and it speaks to the issue of the corporate practice of medicine. So what this is saying is that Mike, as the president and CEO of Central Health, cannot tell a physician how to diagnose a patient. And that is meant to protect the patient, and that's, we are giving the physician their, authority to have independent judgment on how best to treat a patient. We can't, I think the typical example is, I don't know, a corporation, an HMO or a hospital telling a physician to, keep a patient in the hospital for, I don't know, 5 days when they really only need, the doctor only believes they need 2 days. Or vice versa. But, it's just to protect the physician and their independent judgment.
Okay, then.
Yes, and so I completely understand this. Although I think the doctor would say 5, and the other would be 2. But anyway, from what Holly just stated, my understanding is that we, the board, Cynthia, to your point, would determine the composition of this medical executive board. So we, the board, would be able to ensure that there were not anything that we perceive as conflicts. Is that correct, Holly? Thank you.
We all have different definitions
Well,
of what
we, the
conflict
board, would
is,
have to come to a consensus.
including the board.
Yes.
So thank you for answering that. However, I still think that we need to really look at the development of definitions in the context of the legislation and in commonly used context, so that we all know exactly what we're speaking to. So that was just a clarification on that one point that Dr. Bell raised with respect to oversight. But Dr. Bell, do you need to say something before I move on?
No, ma'am.
I saw you raise your hand.
No,
That
that
was
was,
Mr.
Oh, that was, I'm sorry.
That was easy.
Well, I was actually going to pose on the doctors here at the table, is there something in the Medical Practice Act that speaks to independent judgment? Because TMA was looking
Right.
for this language.
And that's exactly what, I'm sorry to interrupt you, Mike, but that's exactly why TMA will oppose a bill if they think that they have restricted authority in any way. They're going to say, we're not supporting it. That's why TMA lobbyists, when I spoke with them, said, this is okay, you're not limiting what physicians can or cannot do, and you won't be telling a physician how to practice medicine.
Well, I think we have to work with the legislative office on this. It could be that on something like independent medical judgment, that we reference that back to the Practice Act, because that's a phrase that
Right.
you all are familiar with.
Right.
and know.
Right.
It doesn't necessarily imply independence from here. It's just independent judgment.
That's correct,
Right.
when dealing with
Yeah.
a patient.
We don't tell doctors
Right.
how to practice medicine.
I mean, they would need independence even from us, Cynthia. to be
Yes.
able
No,
to-
I agree.
yeah.
We can.
I just want to make sure that there are definitions.
The beauty of this board is that you have three positions on the board. You have Abigail,
exactly right.
Charles,
I
and
agree with you.
myself.
Who approves of the physicians on the board? Is that, I didn't see
Appointing
that.
agencies,
It would be
the
this-
appointing
We would
agencies.
be this board.
Okay.
And the appointing agencies, because they're the ones that ultimately appoint the board members. And if a county or a city chose not to appoint a doctor, then we'd be a little bit,
So Cynthia, if I may, the legislation as written contemplates that the Central Health Board is the final say in whether a physician is employed. There is no further step of an up or down vote by the city of Austin or Travis County.
okay. No, I was just referring to if it just so happened that there was a situation whereby no doctor ever got appointed. That's all. So that's a possibility. But, so moving on, I'm gonna, one more time, raise this question. I have asked several times, historically, what are the protocols that we have in place right now? How have they changed with the implementation and with the direct results of DSRIP? How have those protocols changed to incorporate best practices, more efficient and effective healthcare system process for our patients? And I don't believe I have ever received that. So it makes sense to me that that needs to occur one more time in order for us to be able to gauge whether there's a difference in what's being presented. And not with, no, with respect, because and I guess I'm gonna say it like this. When the CCC or you, Dr. Mark, I'm assuming, and you, Jonathan, approve protocols?
No, we don't make medical
Hold on just a
decisions.
second.
Okay, so
So
who
here's what
does?
I'm gonna do.
Where does that come?
I'm gonna try to put your question back into the context of this.
Yes.
So you would like to know how the ability to employ, contract, or appoint physicians would help with patient outcomes based on what we're already seeing.
Well, I'm sorry, maybe I misunderstood. I thought I read in here that they would talk about case management, that they would talk about protocols that would occur in the healthcare system, healthcare delivery system. And I thought I'd seen it.
There's nothing in the bill that states
Nothing in the
that.
bill that says that?
No,
That
gives
they're,
it-
that that's gonna be something that they
That's what TMA is
do?
always protecting physicians' authority. That'll come up to that medical executive committee.
Okay, I think
And
I'm
we-
looking at section B, on page 1, where in addition to the authority to employ physicians, in the manner and for the purposes provided in that section, the board of the district may appoint contracted physicians that the board considers necessary for the efficient operation of the district. To me, the efficient operation of the district always went directly to whether or not we had a system in place that was operating efficiently and effectively, and according to taking care of the appropriate needs of our patient population. You had to have protocols in place. There needs to be a book, or there needs to be something written that says, in this case, this whatever. And maybe, and so
Really
that's,
good.
so with respect to that,
Let me just say one thing, we're getting off subject of the.
well, I guess I don't
posted
understand
form.
how is it gonna change? How are they gonna be making it more effective and efficient when we're using those words already? Because I have, many times, people have come to us and they've told us that they're operating in the most efficient and effective way, that they're also, they have the appropriate protocols in place, that we have a triage system. Y'all have come to us and told us that we are triaging our patients and that we're creating those things. So I think what I'm hearing are the same words.
Can I,
There may be a different
may I-
context.
Let's let the
May I,
vice
Mr.
chair, I mean,
Chairman?
the vice chair has legislative experience, having
Okay.
been
I
a
think-
legislator for 10 years,
I
and she knows
think
exactly what's gonna happen.
in this context, we do need to be careful to stay within the terms of this bill. This bill, the way that I read it, gives this board the authority to hire this executive, medical executive board, and we can go outside of our entire enterprise if we want, if we feel that we need that for not having conflicts, and it doesn't matter whether there are doctors on this board or not. Beyond that, the way that I read this bill, and from what I've heard from our staff, I think our staff has told us that when they say here efficient operation of the district, again, what they're saying is the efficient operation of the district by allowing employees who we currently
Administratively.
who we currently pay, who are doctors but cannot practice as doctors. That is not efficient. This would allow those same employees who have gone to school and have passed their bars and the medical and everything, not the boards. Yeah, I'm thinking of legal. The boards. And yes, to be able to be practicing physicians. However, because we do not have this statute, we do not have the legal authority to allow those individuals who are trained and who have passed their board and we're already paying to practice as doctors. And so it would be more efficient in that way. Is that correct?
Yes, it is. And I do want to, again, state that this is not language that we crafted. This is language that
we're cutting and pasting.
has. And so this is more, think of it more of like a term of art,
That's why I said we're cutting and pasting.
And it's cut and pasted. It's exact language that is in all hospital districts. And it's not something, new that we have created.
Did you say there are 17 that already have this authority? Yes. And my assumption is, I have not read their legislation, that this is the language.
Yes.
Yes, so this is the precedent.
The same language.
This is the same language
and
as
they
all
they all have this language of necessary for the efficient operation of the district.
Right. Thank you.
Well, and doesn't it all go back to, like, if something like an entity, whether it's a governmental entity or private entity or not-for-profit entity, is hiring a physician, and not a patient is hiring a physician,
Right.
paying it.
That's the corporate.
That's right.
Yeah, that's the corporate practice of medicine.
That's
So
correct.
you can't tend to a patient's needs if you are not paid by the patient, unless there's an exception in the
Correct.
law like this.
Correct.
And that is because we are the entity that has been created to provide that service.
Correct.
Well, no, we're the entity that pays the doctor, and it's
Yes,
not.
but we
yeah.
were created to
Yeah.
pay them. We were created
Yes.
to provide that
And
service.
we're paying them
Since
right
we
now.
have no hospital, we are paying for the provision of that service.
Well, not through Dr. Hernandez or Dr. Brown, because they don't work through a FQHC.
No,
That's the
that's
only
right.
exception we
That's
have right
right.
now,
And
so this would create a
that's
separate
why in
exception
my
for it.
head, there was a question raised as to how have we been taking care of all of our patients'
Through the FQHC.
situations.
Through the 2007
It's only been
legislation
through
that
the
was for
FQHC.
Yeah.
So that makes sense. Okay, so I guess when you're explaining it to begin with, you say this is because of outside the FQHC, which does have the ability to do this,
Right.
we need to do this.
Correct.
I just wanted to make sure that
Correct.
that we go over the tree and around the woods to finally get to, because this is why, because we do not do that. We cannot do that. This is why we need this language, so that we can do that. And to protect the other patients, because we do have other patients that are addressed, whose needs are addressed outside the FQHC system. Is that correct?
That's correct.
Thank you. So I guess what I'm just asking for, Jonathan, at some point in the future, is that I still want to know existing protocols, change in protocols. And with respect to this, I'd like to be able to see the difference.
So
Future. In the
without
future.
this legislation, the CCC and Central Health do not establish protocols, because that is the practice of medicine.
Of the medicine.
That's right.
We're not.
What we do
We're
is
not allowed to without this law.
contract.
No, I see that we don't practice it, but I'd like to know what they are.
We don't
Somebody
have
We're
does.
going to have to have
We
separate.
now know, okay, another important, real simple description, because we're not the FQHC that's providing them, and because our doctors do not practice corporate law, it's prohibited,
Yes.
and so we need to have this language in place to be able to cover all the scenarios, right?
I-
Okay.
Agreed.
Thank you. All right.
Managers, any other questions of
Nope.
Caroline, John?
Get 'em up, move 'em out.
Any final words?
No, sir. Members, thank you for the time.
Thank you.
I appreciate it.
I just,
Thank you.
have a,
Caroline, John, thank you for coming. I really appreciate your time, and I know that y'all have been working hard on this, and I can't thank Senator Watson and Representative Howard for doing this as well.
I move adjournment.
is this stuff going to be on the website also, this entire packet?
We can, yes, put it on the
It'd
website.
be good if it's done
Yes.
for this and for
Yes.
the other.
Okay,
All right,
I need
we
to
have
look
a
at what
motion on
you
the floor.
have in your
Is
hand.
there a
but we will-
Motion on the floor by Manager Greenberg, seconded by Manager Bell. All in favor, say aye. Aye. Motion passes. We are adjourned.
Thank you.